just introduce yourself to the group and talk about what you're doing?
Sure. So, my name is Danica Peterson, so I'm a health educator with Sacramento County, and this is Neal here. She's our project director with the program, so both with Sac County. So we do have a cessation objective. That's the one that Elisa shared earlier on the PowerPoint. Our program is a bit new to cessation. We normally work on secondhand smoke, retail policies, and we serve as a focal point for education, information, and policy in Sac County. But we do have the new cessation objective, and we also run our local tobacco control coalition, and that's been around for over 25 years. We have various subcommittees and task forces that focus on more specific issues. So we have the cessation task force, we also have a policy task force, youth and young adult subcommittee, and then we're really focusing on our equity and diversity to recruit new members to the coalition. So yeah, we're doing a lot of policy work, and we serve as a very good focal point for any resources, TA, policy in Sacramento County. So.
And you have the school district folks at the table too. They're
under
the Department of Education,
yeah.
And they also address marijuana as well.
I just want to compliment the people of California for what they have done on smoking. And I don't know whether you can give us context nationally, but I grew up in tobacco farming country in Virginia. And it was the official policy of the state of Virginia to get as many people hooked as possible. So it's really beautiful to hear, to have come out here to college and have been exposed to the beautiful anti-smoking public service announcement campaign, which it was such a culture shift. So I think one thing to be aware of is that we are a very fluid society in California, and don't let go of the public airways messaging because it will reach a lot more people than the one-on-one. And I don't know if I didn't pick up anything in your presentation about are there still public service announcements? Are there billboard campaigns still going on? I'm not seeing them.
Well, the state tobacco control program is a huge media campaign, and I see the stuff about flavored tobacco products everywhere. I live in Elk Grove. And I should just say one thing about the e-cigarette part. UCSF has a lot of science coming out about the harms of electronic cigarettes on cardiopulmonary, especially with inflammation and particulates, and that may be something that this group wants to see in future as well. I think if anything, it's going to be a cardiopulmonary message and not so much a cancer message about all these new tobacco products that are being rolled out by the industry. They're totally reorganizing around. We are no longer burning cigarettes. We are now a healthier alternative, but the science of that, the early science of this is showing those early mechanisms of inflammation and whatnot. It's actually very important for cardiopulmonary.
Yeah, it's an addiction on-ramp.
Yes, that too. Getting the next generation with flash drive products.
So listening to everything, this has been great, and I have one suggestion. Joe mentioned that people cycle on and off healthcare insurance programs, so you can't really tell who will get the benefit from that cost. That physicians have patients, they have to check which healthcare plan on, does that cover it or not cover it, etc. I would propose we get the major players in healthcare insurance in one room at one table, and we come up with universal incentive for smoking cessation. If they all agree that they'll all institute a $20 match the Medi-Cal program, incentive program, then the physicians and healthcare providers know it's accessible to all insurance programs that we've got representing the major players in the state of California, as well as Medi-Cal. It's available for everyone. And if someone is on the system and flips to the other one, that company still gets the benefit for signing up for this universal care, because they know in the end they will get benefit even if somebody switches in or out of their program.
Yes. So just to I think it's a great idea, Bill, and I'm looking at my colleagues at CDPH that maybe they could help convene that summit. A quick initial step would be to meet with Covered California. I know several of the principals there. They represent multiple health plans and not as big a swath as Medi-Cal, but if we get that going, then we can get to the bigger piece, because they can basically mandate it and put it in a contract. So that would be just one example. I think the discussion's been great. It shows how difficult, as I said, quality improvement is difficult. If it were easy, we wouldn't have the RightCare initiative. But it takes figuring out, well, how does my HR work? There are legal things, but you can work through it. So I think taking it back to Elisa, Dr. Tong, we have a very brave group that has stepped forward to talk about their journey, and then maybe as a group we can think, how do you get to the next step? So Elisa, I think maybe you can lead that discussion to close.
Oh, okay.
I
thought you were going to.
I think bringing in the actual reality of a group that is thinking through it, that'll help us close out the day, and then we're all committed, because Hattie's going to be in charge of accountability.
Okay, well, how about that? Silly, you want to come represent one community health? And I just, Mary on our team pulled the UDS data for some of the F2HCs in Sacramento and the surrounding counties, and just some data just to throw up there as a starting point. But the whole part of quality improvement is you can only go up, right? So.
So Sonali Navarrete, Quality Improvement Director at One Community Health. It's good to see some familiar faces here. Welcome. Yes. So we are, as we talked about how do we get this project moving, I think, one of the realities that I see from a systems perspective at the health center level is competing priorities. This is one of, I think it's 12 UDS measures. I can't remember exactly how many they are right now. So how do you prioritize an improvement project when you have a whole lot that you need to address? For One Community Health, smoking cessation and tobacco intervention is not a prioritized measure that we've prioritized for 2019. Doesn't mean that we can't do some work around it. So one of the ways that we've looked at this is including tobacco cessation and intervention with our other expert measures for alcohol and drug screening, for depression screening, and then of course tobacco as well, trying to align efforts where there was already existing efforts. So sometime last year, in the last quarter of last year, we have gone through 2 PDSAs of attempting to address that ask piece of the equation, right? So how just better assessing tobacco smoking status amongst all of our patients. So we PDSA'd a screening form that would allow us to collect that information from our patients. Again, not just for tobacco, but for depression as well as for alcohol and drug screening as well. So that has gone through a couple iterations. And I think the other piece that we've focused on is the MA piece in this work. So that work was led by our MAs to enter in that data into our EPIC system. And then I think the other piece of that was just awareness that this is even a measure that we're tracking at a health center level. And so we share that information with our providers and our teams that this was something that we were going to be looking at and tracking. So we recently had a meeting where we are talking about now our third PDSA related to this, because even though our smoking, the assessment piece, our age smoker has really gone up quite a bit, that second piece about the intervention is where we need some work for sure. And so we're trying to figure out what do we want to focus on as it relates to interventions, utilizing our, we have integrated behavioral health as part of our care teams, and so how do we utilize those staff for certain interventions. We are in a process of reorganizing or looking at the role of our health educators, who at One Community Health have traditionally focused on STI screening. We're expanding their skill set to other conditions, and so looking at utilizing them as well. Patty, you'd asked about data. That has been a big challenge for us. I can get out our smoking status data really easily, not so much who's on a certain medication, what kind of intervention was provided, were they provided with a referral. So it can be developed, but it's not like it's a template that I can just click a couple buttons and it shows me there beautifully what I need. So the data piece has been an obstacle for us. And then just competing priorities. There's a lot of projects we want to move. How do we fit that all in and not overwhelm our staff?
Yeah, I think that's just a great summary of what the real world is that you're committed to it, but you may have 10 or 20 things that you also have to work on. And how do you, so now you have the assessment piece, but then how do we know what's going on in intervention? And to the point that Elisa made, ultimately, what's the quit rate to know that there's an impact? And I think that's something that we probably need to come back to, with Bill and Joe leading in RightCare, because we're also trying to do hypertension control, lipids, diabetes, and weight control. You could add that in. So, Elisa, I wonder if you could, because you have a similar thing in trying to push this within not only crime, which has multiple quality metrics, but UC Davis and the UC system has multiple quality metrics beyond smoking that are valid. So, could you speak to that? Maybe we could get, because I think that is a great point. Stay up here because I think we want to have that conversation. You brought up a point, Sally, that was so good, which is everyone has 10 or 20 things, and then how do you move that along? So maybe, Eliza, you could start that and then get other feedback on how do we manage that.
Well, I'm always learning, and I think as Mary pointed out to me when we pulled this data last week, I think you guys, for the UDS measure, it's even more challenging than what we're doing for crime, which was locked in at your last assessment of someone over the past 2 years, whereas I think UDS and value-based care, all this stuff, new stuff CMS is rolling out, is saying, what was the last time you saw somebody? So that's even a bigger,
we're going to see a performance drop.
Right. So I want to just clarify that it should not be like apples to apples for what is going on with crime, because that was a locked-in measure that everyone's now just kind of preparing for the next quality metric they've got to meet. So kudos to you guys for even getting to this stage already. And how do you maximize what you're already doing? I think you've already touched on that. It's a team-based model. Using behavioral health. I know, like for Cancer Center, social workers have been a tremendous resource in terms of while they're addressing all these other multiple challenges of the patient, trying to also see, is this key one also there too, but sort of integrating it into their workflow. So I think that approach is great, but also that's why I also want to get the QuitLine e-referral in for you guys. And at UC Davis, we're challenged because I think when we first created it, the e-referral, it's built for only physicians to order. So the MAs can pen, but they can't sign the order just yet, and I think it's going to move mountains before we, get the approval for an MA to just sign it themselves. But, this is something, if you're starting fresh now, you have that opportunity to address it and say, for our workflow, we want social worker to sign it, we want nurse to sign it, we want, MAs to sign it, or something where you set the policy early on, you now have that opportunity to do it even better.
You hear that, Dr. Khan?
I was wondering, because getting back to that question, if we want to deal, maybe there are 10 things you're trying to move in a given year, looking for. Have you focused in on high-risk patients, which might have multiple problems of behavioral health issues, smoking and diabetes, and then say, that way we're kind of targeting multiple things with an intensity and perhaps knocking off multiple measures, which is a benefit to that high-risk population. Have you thought about that? And then
yeah, we have started that discussion in terms of the interventions, right? In terms of really, when you think about that care team approach, who can you utilize on your team to support a certain intervention, and at what acuity level or cut point do you provide a certain intervention? It's not everyone needs the same level of support. So we have started having those discussions with those improvement areas that I'm more intimately aware of at one community. But really, as a health center, what drives us a lot is two things. It's those UDS measures, and honestly, it's whatever's incentivized by the plans. So right now, tobacco cessation is not a prioritized or incentivized measure by the plans, at least in our network here. So, but it's something obviously that needs to be addressed. So hence the how do we integrate this into existing work where we can make an impact on our patients.
I wanted to say something that relates to our work that we're doing, and I think everybody else in this room probably would echo.
Would you please say your name and your organization?
Hello. So my name is Tasneem Khan. I'm the Chief Medical Officer at One Community Health.
Thank you for being
And
here.
Yes, thank you for being here.
thank you for putting this together. I joined the organization 10 months ago, and I think just to talk about our story, when I look at that, I'm a little embarrassed, but I think our story was really around the data and really knowing, really validating the data. So we took a lot of time doing that, and now now that we're at that point, now the current, space that the challenge that we face is really getting providers on board and getting them engaged in this, because we can throw out all the PDSAs and do everything, but getting the teams, the care teams engaged into actually going through the workflow, because the workflow in Epic is, it's stepwise. It's not just identifying the patient, it's actually initiating the intervention, documenting in the right place so the UDS measure is captured. So I think we kind of are, looking at that, and I do like the idea that you put out there about identifying those patients that are particularly augmented risk because of their other comorbidities, and maybe looking at those in a more detailed way. So just wanted to share that.
I think one of the key things that Dr. Kohatsu said is that this positive health benefit can accrue in that same year. So it's a now thing, and to look at what are the incentives that the state can deploy to get the providers to yield the current opportunity, instead of thinking of this as a long-term thing, which I always have. I want to learn more about that immediate benefit.
Well, also just to add to that, and there's a questioner on deck. But that's the reason this was not just a back of the napkin health economic evaluation. We had expert UCSF health economists do that. And so it's actually cost savings. There are very few things, even in prevention, that are cost saving. There are a lot of good buys, which is cost effective mammography. Childhood immunizations, smoking cessation, cost savings. So for making that investment, not only is it rendered over short term, at least in the circumstance we described, cost savings. So we wouldn't have that discussion with the CFOs. But I think there was a question you said.
Yeah, so my name is Xavier Woods. I'm from UC Davis. I'm a cardiologist. I'm the new medical director of cardiac rehabilitation. And so I'll throw the idea that there is a model already where we can bring together all these risk factors and manage them in the same place. It's what we do in secondary prevention in cardiac rehabilitation. We can do smoking cessation, we do lipid control, we do blood pressure control, we do diabetes management, we do activity and physical activity, prescription, and monitoring over a period of 3 to 4 months after the event. So it's not a primary prevention model, but it is a model where all these components come together, and it's cost effective, it affects outcomes. So it provides in a conversation on how to bundle these things together. We could, one avenue could be taking a look at that model and how it could be applied potentially primary prevention. And I'll put a kudos to the UC Davis health plans who actually will pay for patients who have high risk factors but not yet an event for them to come to cardiac rehabilitation. Not all health plans do that. I believe Medi-Cal doesn't do that. It's something, an avenue that potentially could be developed and grown from that perspective.
Could you elaborate a little bit more on that model, that bundled model that you use once somebody's had an event?
Yeah, so after you've had a heart attack or bypass surgery or heart failure hospitalization or percutaneous valvular intervention, Within days to weeks from discharge from the hospital, you can actually go to the cardiac rehab program. It's usually 36 sessions for over 3 months. So it's 3 times a week. So it's face-to-face contact for an hour with these patients, in which they come. We have a psychologist, we have a nutritionist, we have a physician medical director, nurses, and exercise physiologists. Some programs have pharmacists involved. We do multidisciplinary rounds. We intake everyone. We review all the risk factors, and then we channel, make referrals, make for smoking cessation, we make the proper referral, and we identify that. And then we do the hard work, which is face-to-face with the patient 3 times a week. And sometimes it takes 20 visits before we get them to say, you know what, maybe I should think about quitting smoking. But we bring it up every time. We talk about it. Are you ready to discuss that today? And so it is truly a face-to-face intervention, a longitudinal intervention. There is a lack of utilization. That's the problem in that space right now. Nationally, probably 20 to 30% of patients that qualify utilize intervention. There's a national, Million Hearts have a national initiative to try to get us to 70% participation by 2022, I think it's the year. And that's on the secondary prevention space.
What do you see as the barriers for that? Because I'm just thinking about another program that UC Davis has that could really benefit from those same methodologies. So once somebody gets their heart CT scan and we know that they are headed toward your clinic, maybe it could be done in a more preventive way.
We have some very cardiac rehab barriers. One is, it's already been mentioned, is time, and people are not going to interrupt work to come to us. So hours, after hours, Saturdays, that's one of the barriers. One major one that we would like to take the challenge of changing is co-pays.
Is what?
Co-pays. Patients have to pay $10 and $20 every visit to the gym. That's $600, $800 and stay engaged. So essentially, the people who have the extra money are the ones that are coming. People that don't have the extra money to pay $10 and $20, they negotiate with us. Oh, can I come over once a week? And we only afford $20 a week. And so that's the biggest one, the 2 biggest challenges that I think are important for us to recognize. There are lots of psychological, medical challenges. Those we deal on a case-per-case basis. But in terms of systemic, those are 2 major challenges that we would like to find ways to overcome.
Dr. Bourne.
Yeah, I'm sorry, I know it's getting very late. I'm a retired Kaiser cardiologist, and I just want to speak to that for a second. My role also involves with the American College of Cardiology prevention piece and the tobacco cessation piece. And I'm now working with Encore, which is trying to get retired physicians into community health centers. But the Kaiser model for cardiac rehab is one that I think is a very good one. Patients are brought in for 1 or 2 lectures. They meet with the nurses, nurse managers, that then will be working with them over the next few months. And over those next few months, they will do the work at home. They will be getting computer lectures so that they can get the information that they need. But then there's weekly or every second week conversations on the phone to try and motivate them. So that doesn't require them to come into the hospital. The compliance rate is near 100%. And I think that model is what we could go for, even for primary prevention as well. There's companies now that have that in the cell phone. I won't go into that, but that would be a possibility. And then they have the nurse talking to the patient after they input the information just onto the cell phone. So it doesn't have to be a Kaiser system, but these other corporations are doing it so that we could use that, not just for secondary prevention, but maybe even for primary prevention as well, to try and help motivate people to make the changes that they need to for blood pressure, exercise, change their dietary habits, and smoking cessation.
We've looked at the data in terms of the effectiveness of these programs, and it's been reported in meta-analysis that one component that's important for survival is the physician management of the medications during the period of time. So there are lots of programs that do not manage medications, and those programs, the data on survival is much less strong. The data is clearly strongest when the physician is following on the physiological progress of the patient and the medication, and managing the medications within the program. So I think for primary prevention, the home-based programs and the telemedicine components and whatnot may be very applicable. I worry about the secondary prevention where we're basically you show up to the hospital in MI, we give you 5 medications, and we send you out the door within 48 hours, and then you're going to get on the treadmill at home, and the next thing your blood pressure tanks, and you're in the ground. And we see it at the gym all the time. So I mean, there are lots of things like this, especially in the new patients, that is best if they're physically in the gym. That's the secondary prevention. Where you go for primary prevention, there's quite a bit of room there to be flexible and innovative, and so also make it affordable.
So Danica and I will be collaborating in February at the Sacramento District Dental Society, and I think that it's time that we get dental people involved in this conversation, because in a dental office we may well have more time to sit there and have a conversation with the patient. So we're trying to promote dental offices to integrate this tobacco cessation messaging, whether it's smoking, vaping, dipping, chewing, all the various ways that nicotine can be delivered. So we're really excited to be doing that. I'm hoping Jerry over here, once he gets his little group of people together, will reach out to some dentists or hygienists, retired, to help with that messaging. As far as FQHCs, who made the comment about you have a higher population of smokers? I'm hoping that we'll see some of the dentists who are in these clinics from these FQHCs at the SPDS meeting next month, so that we can hopefully tickle their brains a little bit about how important this conversation is to have in a dental healthcare setting. And then one quick question. Has anybody here seen the Juul commercials on TV? Are you horrified? Okay, just checking to see. I knew it wasn't my imagination, but I don't know if they were targeting specific populations or not, but one seems to be focusing in on an African-American gentleman who's quit successfully for 2 years now because he started using Juul. So it starts out with a disclaimer talking about how nicotine is a highly addictive chemical, and then it segues into this, gee whiz, Juul has saved my life. It doesn't talk about any of the other negative things about juuling, but I was very horrified. And then there's a second one that I think it's a Latina lady who's now quit, and how Juul has saved her life. Who monitors this stuff? I mean, is it the Federal Trade Commission? How come cigarettes aren't on the TV again if juuling is on there as a cessation device when in fact it's really not? Okay.
Well, we want to thank everyone for coming, especially Neal and Elisa, for an excellent program today. I think it raises a lot of questions and helps us as we go forward with that. We want you to know that you saw a lot of data and a lot of slides and graphics today, but the reality is all of us know a family member, a friend, or a patient who has died much too early because of cardiovascular disease. The bottom line for RightCare Initiative is we want to not only make progress in this, but we want to prevent those premature deaths for those loved ones. Thank you for attending today, and drive safely when you leave here. We also have our next meeting for February 11th on Monday, right here in this building. And for those interested in continuing medical education credit, 1 hour, please give your form to Brian, and he'll facilitate that for you. Thank you very much, and Happy New Year.